Hello everyone. Today I have got a summary presentation prepared for colposcopy. I hope you'll find this useful. Now I remember when I was revising for my MRCOG exam, I found it quite difficult to resource all the important bits that you need to know for colposcopy, but more importantly, I did not find anywhere where I would just be able to refer back to and know exactly what I needed to know from the topic of colposcopy for the MRCOG exams. So I'm hoping this will help you. Make sure you hit the like button and subscribe to the channel if you haven't already, and please share it with your friends and colleagues if you found this presentation useful. Okay, so the NHS Cervical Screening Programme, it's shortened to NHSCSP. Now, I'm sure you all have come across it. You may have personally had smear test or have done this for your patients. Now, the aim of the programme is to reduce the incidence and mortality from cervical cancer. Now, there's certain age limits on this program, and the reason for that is it's not shown to reduce incidence and mortality from cervical cancer under the age of 25, which is why you, as you probably most of you know, that this screening program only starts from the age of 25. So from the age of 25 to 49 years of age, you will be called for screening every 3 years. From the age of 50 to 64, the frequency of invitation is every 5 years. Above the age of 65, if there have been any recent abnormal tests, or there's been the patient's not had any adequate screening test, reported since age of 50, then they may be invited for an extra or some more screening. So the patient first receives an invite basically at the age of 24 and a half. Is when the first invite goes out, and the screening program would officially start from the 25 to 49 age, calling every 3 years, and from 50 to 64 every 5 years. Quite important figures to know for your exam. Okay, so your patient's been for their smear test. Now, what do you do with the results? Now, the results will come as HPV positive. So if the screening test has detected the HPV virus, then a cytology test would be carried on the sample, and based on what the sample in the cytology is, it will then result in what kind of action needs to be taken. So, for example, if there have been 3 consecutive inadequate smears, then you would refer this patient for colposcopy, and this would be on a 6-week referral pathway. If it shows borderline changes in cells with HPV positive, then again you refer this patient for colposcopy within 6 weeks. If there is low-grade dyskaryosis along with HPV positive, then again you'd be referring these patients on the 6-week pathway. If there is any high-grade changes, so whether that's moderate or severe, or there is query invasion or glandular neoplasia, or the cervix looks abnormal, then you'd refer these patients on a 2-week pathway to be seen in colposcopy. Now, there can be several reasons why patients might want to withdraw from this screening program. Now, if the patient has a low risk of cancer, which means that they haven't had any sexual contact, intimate contact with a male or female, then they may wish to withdraw from this program. If a patient has physical or learning disability, which because of which they find it the smear taking quite difficult and quite distressing, then again they may not wish to receive further invitations. If, for example, it's a terminally ill patient and they may not benefit from screening, then again they may wish to withdraw themselves from the screening program. If a patient's had something like FGM, which is female genital mutilation, again that might be a reason why the patient may not want to keep coming back for these smear tests and may need some sort of specialist input. So these patients with mutual agreement could be referred to, for example, gynecology clinic for specialist gynecology input. If the patient does not want to participate in the screening program, then they may wish to withdraw themselves as well. So who would we wish to stop the program for? So patients who have undergone a total hysterectomy. So it's important to note that patients who've only had a subtotal hysterectomy still have a cervix and will need to go through cervical screening, but patients who've had congenital absence of cervix, being a male to female transsexual, or have undergone a radical trachelectomy for cervical cancer. Now these are the patients that you may wish to stop the recall on this cervical screening program. Okay, so this slide talks about advice given to women who have undergone a LEETZ procedure, which is a loop excision of the transformation zone. So you advise these patients to avoid tampons, vaginal intercourse for 4 weeks, and swimming for about 2 weeks. You also advise them that driving is not not as advisable, and they can carry on doing their daily activities and light exercise. Again, travel is not contraindicated, but they may wish to check with their insurance, as some of the complications from the LEETZ may not be covered if they were to travel abroad. If they've had a single loop and single treatment of the cervix, which is less than 10 millimeters, in length and depth, that it's unlikely to cause things like preterm labor and preterm rupture of membranes. It's important to let them know that single loop excision again is not associated with any increased risk of infertility, but may increase the risk of mid-trimester miscarriage. Now, if there is invasive disease, so excisional form of biopsy is recommended. Now, what this means is if you look at a cervix in clinic under colposcopy and there is very obvious abnormality there, then you would want to do something called as an excisional biopsy, which means that you are going to try and take away as much and all of that abnormal area with a bit of depth to it, so that when it's analyzed for histology, you've got some clear margins. Now, excisional biopsy is recommended if most of the ectocervix is replaced with high-grade disease, when low-grade colposcopic change is associated with high-grade dyskaryosis, or worse, when a lesion extends into the endocervical canal, sufficient cervical tissue should be excised to remove the entire endocervical lesion. Now, sometimes you look at an abnormality and there would be two options, either to do some surgical excision or to do something called ablative technique, and try and get, to try and remove the abnormality. Now, ablative techniques include things like cryocautery, or things like laser, for example. So when is this suitable? when the entire transformation zone is visualized, when there's no evidence of glandular abnormality, when there's no evidence of invasive disease, when there's no major discrepancy between cytology and histology, and only in exceptional circumstances it's done for patients over 50 years of age, because usually the standard treatment for anyone who is over 50 years of age with high grade abnormality would be to offer them excision. Okay, so we get to some numbers now. So over 50% of CIN1 lesions will regress over 22 months. So these are the low grade changes. Follow-up should not be less than 12 months. So that means follow them up, over in a year's time. If the lesion persists for longer than 24 months, then treatment should be discussed with the patient. So low-grade lesions can have conservative management, like we said, follow up in a year's time, but also cryocautery could be advised for low-grade lesions, which involves a double freeze thaw freeze technique. So you freeze for 3 minutes, thaw for 5 minutes, and then freeze again for 3 minutes. That sort of technique to help with regression of the lesion. So when excision is used, which is you're taking an excisional biopsy and trying to remove most of that area that's got abnormality on it, then at least 80% of these cases should have the specimen removed as a single sample. Now, when you are offering excisional biopsy for high-grade lesions, it's important to note that depending on your transformation zone, there's 3 types of transformations. There's type 1, type 2, and type 3. If it's a type 1 transformation zone, then your depth needs to be above 7 millimeters but less than 10 millimeters. If it's a type 2 transformation zone, then it's between 10 to 15 millimeters. And if it's a type 3 transformation zone, then the depth should be between 15 to 25 millimeters of this excisional biopsy. So occasionally we have to offer patients repeat excision. Now the CIN3 extending to the margins and to the lateral and the deep margins, then there is higher incidence of recurrence, but it doesn't always justify offering a repeat excision. If there's no evidence of glandular abnormality and there's no evidence of invasive disease and the patient is under 50 years of age, it's important to inform your patient that although there's high risk of recurrence and they should wait for the test of cure smear, which will be in 6 months after the first excisional biopsy, but and although the risk of recurrence is higher, but it doesn't justify doing a second procedure if they're under 50 years of age. However, if your patient is above 50 years of age and there is CIN3 at the lateral or the deep margin, then they should be offered a repeat excision to obtain a clear margin. So FIGO stage 1A1 cervical cancer can be managed by local excisional technique if the excision margins are free of both CIN and invasive disease, if the pathologist and the MDT reviews histology, and if the invasive lesion is excised but CIN extends to the excision margin, then repeat excision should be performed to confirm complete excision of CIN and to exclude further invasive disease. If there is glandular abnormality, then an excisional biopsy is recommended. Normally it's a cylindrical biopsy, which means that the depth of this biopsy goes into the endocervical canal, so you're obtaining a good amount of tissue from the canal to get rid of this abnormality. Now, if there is incompletely excised CGIN, which is the glandular intraepithelial neoplasia, then the clinician should be satisfied that the specimen submitted has been thoroughly sampled in the labs and that the margins of the specimen are free of disease. If the margins of an initial conservative excision are not free, it is reasonable to offer a further attempt at conservative excision in order to confidently exclude invasion and obtain negative margins. The colposcopy or MDT should then help to guide further management. Now, occasionally patients would prefer a hysterectomy for glandular neoplasia, and a simple hysterectomy might be considered if fertility is not required, positive margins are present after an adequate excisional procedure was done, treatment by colon biopsy is followed by further high-grade cytological abnormality, patient unwilling to undergo conservative management, an adequate cytological follow-up has not been possible, example because of cervical stenosis, other clinical indications for the procedure, like for example invasive disease has been, and also that invasive disease has been confidently excluded. Now, cervical screening for women during pregnancy. Now, routine screening should be deferred until postnatal. If there is abnormal cytology, then these patients should be offered colposcopy in late first or early second trimester, unless there is a contraindication. However, for low-grade changes and on the basis of a positive HPV test, the assessment could be delayed until after delivery. Previous colposcopy being abnormal and in the interim the woman becomes pregnant, then colposcopy should not be delayed. If a pregnant woman requires colposcopy or cytology after treatment, like for follow-up of untreated CIN, her assessment may be delayed until after delivery. Unless there is an obstetric contraindication, however, assessment should not be delayed if the first appointment to follow up cytology or colposcopy is due following treatment for CGIN. The test of cure appointment should not be delayed after treatment for CIN 2 or 3 with involved or uncertain margin status. So colposcopy in pregnant women require high degree of skill. CIN 1 if it's suspected, then repeat colposcopy 3 months following delivery. If CIN 2 or 3 suspected, then repeat colposcopy at the end of second trimester. If pregnant women already is advanced beyond this point, then repeat 3 months after delivery. If invasive disease is suspected clinically or colposcopically, a biopsy adequate to make the diagnosis essential. However, the biopsy should either be done as a cone, wedge, or diathermy or loop biopsy, which have all got increased risk of hemorrhage, and this should only be taken place in a place where there is facilities to be able to measure, to be able to deal with a major hemorrhage. Punch biopsies cannot always exclude invasion and should be avoided. So women who are HIV positive should have annual cytology performed with a initial colposcopy at diagnosis of HIV, and after that it is a yearly smear test that they will have. This is quite important and also comes up as an exam question. Well, there you have it. So that's a good summary of colposcopy and everything you may need to know for your MRCOG exams. I hope you found this useful. Now, if you have any questions or I have not been able to clarify something for you, then do drop me a comment down below. Also, you could email me, and I could answer this for you personally as well. I'll also be doing another presentation on the different flowcharts that again you may need to know for your exams. So look out for another small video where I'll be going through the flowcharts in detail. I hope you found this useful. Don't forget to give this video a thumbs up and subscribe to the channel if you haven't already.